Hello, today we'll be discussing cord clamping in term newborns and its effects on the incidence of hyperbilirubinemia. My name is Andrea, and we have Bryson, Emily, and Trang. When we were researching delayed cord clamping and hyperbilirubinemia, we learned that delayed cord clamping can increase the risk of hyperbilirubinemia. However, it can also decrease the risk of complications such as necrotizing enterocolitis. We also found that hyperbilirubinemia was prevalent in about 80% of newborns. And the reason for this is because newborns have immature livers and their red blood cells break down a lot quicker. And so this can cause a buildup of bilirubin in the bloodstream. Hyperbilirubinemia can lead to further complications such as kernicterus. This is a type of brain damage that can impair neurodevelopment and even cause hearing loss. For this reason, we wanted to investigate whether there was a reduced incidence of hyperbilirubinemia for term newborns born between 37 to 40 weeks gestation in cases of delayed cord clamping greater than 30 seconds versus immediate cord clamping within 30 seconds or less during the first 72 hours of life. For the first review of literature, we have Shao. It had level 1 evidence. It had one early cord clamping group, as well as two delayed cord clamping groups. One was 30 to 60 seconds, and the other was 61 to 120 seconds. In the DCC group of 61 to 120 seconds, that group had a slightly higher transcutaneous bilirubin level compared to the ECC group. However, it was not statistically significant. There was also no difference between the rate of phototherapy between the two groups, and it was not statistically significant. However, there was one limitation, and this was that there was a larger sample size in the ECC group for peripheral heel sticks. And the heel sticks were used to measure the hemoglobin concentration. And so this could have potentially caused a disproportionately skewed the data. However, the evidence for this study was high quality, and it was collected with a randomized control trial.
Another literature review that we did was the American College of Obstetrician and Gynecologist Committee. It assessed the effect of delay versus early umbilical cord clamping and neonatal outcome using a randomized control trial. The study measured ECC as less than 1 minute after birth, and DCC was defined as more than 1 minute after birth. Reviewers discovered that newborns in the ECC group had lower hemoglobin concentrations when compared with the DCC group. This difference in the hemoglobin concentration was also prevalent for 24 to 40 hours later. At 3 to 6 months of age, the infants in the ECC group were more likely to have iron deficiency. Jaundice requiring phototherapy was less prevalent in the ECC group, with 2.47% compared to 4.36% in the DCC group. With that being said, there were some limitations to the study, such as ideal time for umbilical cord clamping in particular circumstances, such as maternal hemorrhage, immediate infant resuscitations, maternal hemodynamic instability, and abnormal placentation. The study is a level 1 high-quality evidence collected with 15 randomized control trials.
The next study that we included was conducted by Shen in 2018. This study evaluated the effectiveness and safety of delayed cord clamping in different timings using a randomized control trial of 720 term infants assigned to early or delayed cord clamping. Moreover, this study utilized several groups that received delayed cord clamping at various intervals, such as 30 seconds, 60 seconds, 90 seconds, 120 seconds, 150 seconds, and 180 seconds. Also, it included a group that received DCC until no umbilical cord pulsations were noted. In this study, the use of randomization and a large sample size selected from a pool of subjects at the Tianjin Central Hospital of Obstetrics and Gynecology yielded data representative of the population of newborn infants in China from December 2014 to May 2015. Also, the use of blinding of the health professionals tasked with evaluating the newborns and the personnel in charge of the laboratory test reduced the risk of bias. However, the performing physicians could not be blinded in this study. The results of this study included DCC for at least 60 seconds can increase hematocrit and hemoglobin levels at 24 and 48 hours. Limitations to this study do include the lack of assessment of factors that could affect the outcome of DCC, such as spontaneous inspirations. Also, participants for this study were sourced from a single healthcare center. However, this study yielded high-quality evidence on DCC and the different timings.
The Peking University School of Nursing conducted a systematic review and meta-analysis of randomized controlled trials, which examined the long-term effects of DCC versus ECC of infants after the neonatal period. ECC was defined as no later than 60 seconds, and DCC was no earlier than 60 seconds. Results from the review found that DCC increased hematocrit and serum ferritin for preterm deliveries between 6 to 10 weeks after birth. DCC decreased the incidence of anemia and iron deficiency among term infants after 6 months and iron deficiency anemia between months 4 and 12. Meanwhile, it increased mean corpuscular volume before 6 months of age, hemoglobin after 6 months, serum iron between 2 and 4 months, serum ferritin less than 6 months and after 6 months, and transferrin saturation between 2 and 12 months. In conclusion, DCC improves the hematological and iron status of term infants after the neonatal period. Limitations to this review surpasses the timeframe in which this paper aims to investigate the effects of ECC versus DCC within 72 hours after birth. However, this was taken into consideration when finding a conclusion to this investigation. Regardless, the systematic review and meta-analysis proves that this is a high quality evidence.
The collective conclusion of the studies discussed in the literature review include support that term infants could benefit from DCC at least 30 to 60 seconds. Also, DCC improved iron storage and increased hemoglobin levels. However, DCC caused a slight increase in the incidence in hyperbilirubinemia. Therefore, there should be guidelines to monitor and treat jaundice in term infants who receive DCC. Moreover, each study had uniquely defined timeframes for DCC and ECC. So further research is needed to support a universal delayed cord clamping guidelines in the clinical setting.
According to the American College of Obstetrics and Gynecologists, DCC helps improve the hemoglobin levels, iron stores. However, it increases the incidence of phototherapy. These findings were consistent with the upwards literature. A study conducted by Zhao found that DCC increased hemoglobin, serum iron, serum ferritin, as well as transferrin saturation. Similarly, the study conducted by ACOG showed that the ECC group had significantly lower hemoglobin concentrations compared to the DCC group. Both studies conducted by ACOG and Zhao found consistent findings showing that there was a lower rate of jaundice requiring phototherapy in the ECC group compared to the DCC group. For this reason, ACOG recommends that that DCC for 30 to 60 seconds should be done for term newborns. However, there should be mechanisms in place to help monitor bilirubin levels for term newborns to help determine if they develop jaundice.
Although there are no policies on delayed cord clamping within the Long Beach Memorial Medical Center policies and procedures, the World Health Organization states that delayed umbilical cord clamping, not earlier than 1 minute after birth, is recommended for improved maternal and infant health and nutrition outcomes. Studies appraised during this investigation include data that there are benefits of DCC, and ACOG's guidelines concur that DCC results in improved health outcomes despite evidence that it may put the infant at risk for hyperbilirubinemia. However, when checking St. Mary's Medical Center's site, delayed cord clamping is offered as a low intervention childbirth option, but there was no accessible policy. The lack of policies on delayed cord clamping suggests the need for further research to implement evidence-based policies in hospitals.
So we do have some recommendations. Evidence drawn from the literature appraisal earlier in this investigation indicates that DCC can be more beneficial than ECC. However, the correlation of DCC and its effect on reducing the incidence of hyperbilirubinemia is not supported. So it is recommended to research the impact on other outcomes beyond hyperbilirubinemia, such as iron stores, blood transfusion, and necrotizing enterocolitis. Further research will provide more reliable data to make informed decisions and implement practices that benefit the infants. The WHO guidelines also recommends regarding cord clamping during specific neonatal outcomes. One strong recommendation is that the umbilical cord should not be clamped earlier than 1 minute after birth if the term newborn does not require resuscitation measures. If permitted, DCC should be performed for all births for at least 1 to 3 minutes while initiating neonatal care. The third recommendation is to implement an algorithm to assist healthcare professionals in determining whether or not to perform delayed cord clamping based on the specific circumstances of each birth. The algorithm should consider the factors such as the gestational age of the newborn, fetal well-being, parental preferences, and maternal health risks and risk factors. Implementing such algorithm can help healthcare experts deliver evidence-based care while considering the individual's factors and circumstances of the birth. It will also promote the best possible outcomes for both the mother and the baby. There are some financial implications. Delayed cord clamping does increase the hemoglobin level at birth and improves iron stores in the first several months of life. The infants would need to receive phototherapy to prevent further complications. The infant can receive either home phototherapy or inpatient phototherapy. For home phototherapy, it can cost about $640 per day. Total cost of 2 days treatment can be about $512,000 versus inpatient phototherapy, IPT, it can cost about $2,100 per day if the mother and the infant need longer birth admission stay. Then the cost would be $1,000 per day for IPT. Total cost of 2 days treatment would be $1,255,800. Home health phototherapy is cost effective and 3 times lower compared to phototherapy for inpatient hospital care. On the other hand, immediate cord clamping poses a higher risk of iron deficiency during the infancy and childhood. So the cost of anemia screening, for example, CBC can cost about $140 to $622 without insurance, and it can be around $11 to $20 with insurance. Vitamin and iron testing can cost about $108 to $350 on average. Once the infant is diagnosed, anemia therapy can be initiated $18 to $500 per month, depending on the type of anemia and the treatment that are needed. A more invasive treatment such as iron infusion can be done at the hospital, which can range from $400 to $3,000 per iron infusion treatment.
Based on the findings of our research, there is a need for future study on this topic. The topics that need further research include the optimal timing of delayed cord clamping that results in improved patient outcomes for the mother as well as the newborn. Sufficient research and data on the risks, benefits, and outcomes of DCC to establish evidence-based practice recommendations is also needed. Future research should also investigate stem cell and plasma transfusion enhancement through DCC, especially in immunity and host defense systems. Cord blood immediately after birth contains high amounts of hematopoietic stem cells and colony-forming cells. Moreover, delayed cord clamping is a cost-effective method of transfusing these cells to the newborn. The types of research that can be done to meet the needs for future study include randomized control trials, meta-analysis, and systematic reviews to establish a recommendation for the duration for DCC. Establishing a universal duration for DCC is essential before implementing policies and procedures at the hospital level.
The appraised studies showed that DCC is associated with increased hemoglobin concentration and iron stores. On the contrary, there was an increased incidence of hyperbilirubinemia that led to the need for neonatal jaundice treatment, such as phototherapy. This indicates that DCC is found to have improved neonatal hematological outcomes, but does not reduce the incidence of hyperbilirubinemia compared to ECC. The lack of universal delayed and early cord clamping contributed to determining whether DCC was effective in reducing incidence of hyperbilirubinemia in neonates, in addition to the lack of available hospital policies. The timeframe in which data was also obtained varied from study to study and could not be confined to the first 72 hours of life as initially proposed in this investigation. Therefore, establishing a universal duration for DCC is essential before implementing policies. This could be in the form of randomized controlled trials, meta-analysis, or systematic reviews to obtain adequate data and formulate a universal recommended duration for DCC.
That concludes our presentation. Thank you.
Thank you.
Thank you.
Thank you.